afternoon, everyone. I'd like to thank the sponsors of today's briefing, Brandon and Bill and others. I think it's unfortunate that I'm up here again talking about this. I would really love to not have to talk so much about ADAP and the crisis and the situation where so many people find themselves in. Maybe this time there'll be some different effects and we can move past this. So don't feel like you have to look at me. My slides are up there. I know it's a little awkward, but the information I will be talking about is on the wall over there. I'm going to give sort of a general overview of the ADAP programs as they stand and sort of how we got to this crisis point and why we are at such a crisis point. The National Alliance of State and Territorial AIDS Directors represents this Health Department HIV/AIDS programs. So the AIDS directors have responsibility for care and treatment, prevention, viral hepatitis, STD programs. Specifically, in terms of our work on ADAP, we work very closely with the ADAP coordinators in all the states who give us all sorts of data so that we have to give to you all about what's going on in the states. You can go on. So we really find ourselves in a situation, and we call it the perfect storm, where you'll see that there's any number of factors that have affected ADAP programs. State fiscal crises, we know that the state budgets have impacted the state's ability to continue their contribution, the state general revenue fund contributions to this program. In this country, for the last several years, we've had increased efforts on expanded testing and finding those who don't know their HIV status and getting them into appropriate care and treatment. There's been minimal federal increases in the federal appropriations. And one of the really big factors this time around is increased demand due to unemployment, due to people losing their insurance and needing to rely more heavily on Ryan-White programs, including ADAP. I also just want to say before we start talking sort of specifically about the ADAPs, that one of the things that you'll see, ADAPs vary in how they look in terms of their eligibility, how many people they cover, how many drugs are on the formulary, and part of it is really how many gaps they need to fill. And a big factor of variability is what the Medicaid program looks like in any one state. And obviously, Medicaid's vary tremendously. So I think that is important when we're keeping in mind some of these discrepancies and some of these differences between programs, that Ryan-White is a gap filler, and ADAP is a gap filler, and in some states that gap is huge. And ADAPs just simply cannot fill it all. So in terms of client demographics, I'm just pulling out some key pieces here. ADAPs, the vast majority of ADAP clients are racial and ethnic minorities. 57% are Black and Hispanic. Almost half of the clients are between the ages of 45 and 64. 77% of ADAP clients are male. And that's generally because women have babies often, and that gives them access to Medicaid more often than it would give childless adults more often in this scenario. 77% of ADAP clients have incomes at or below 200% of the federal poverty level. And I think that is really key to remember. These programs are really reaching those who need them the most. Of that, 45% of ADAP clients are at or below 100% of the federal poverty level. Also, 67% of ADAP clients are uninsured and have no other access for medications. In terms of enrollment and utilization, you'll see, although it's kind of hard to see, but you'll see that there was a jump in 2009 in terms of how many people were relying and enrolling into this program. In 2008, client enrollment increased by an average of 1,554 new clients per month. This is the largest increase that ADAPs has seen maybe ever. So it really was unprecedented, the amount of clients who were coming to the doors of ADAPs and enrolling into the programs. Additionally, ADAPs are providing medications to a larger number of people. So the people in ADAP are needing far more consistent access to their treatments. The national ADAP budget is $1.6 billion in FY 2009, which is a 5% increase from 2008. You'll see there, or you could if it was larger, that ADAP budgets are made up of a number of factors, and the federal appropriations is only one of them. The state contributions and rebates from pharmaceutical companies are also key. And I'm going to interrupt my presentation for just a few minutes while we hear from a specialist speaker.
Thank you, Ann. Apologize. We're joined by Senator Richard Burr from North Carolina. He has a vote in 7 minutes, which is actually less time than Donna, who had 22 minutes to get over to the Speaker's office. Senator Richard Burr was first elected to the U.S. Senate back in 2004. Prior to that, he represented a congressional district around Winston-Salem, North Carolina. He's long been a champion for a lot of HIV-related issues and has recently introduced legislation to try and address the ADAP crisis. So with that,
Senator, I will be brief. I want to thank you for being here and continuing to raise the issue. When ADAP was created for one very specific reason. It was to make sure that individuals affected by HIV/AIDS had the treatments they needed to extend their life. To wait for new therapies to be developed, and hopefully at one point to have a cure. Unfortunately, where we are with a $101 million hole means that the spirit of everything that ADAP was created for sort of goes by the wayside. If you're lucky enough to be in a state that hadn't used all their money, you get drugs. If you're in the state of North Carolina or a few others, then we're going to pick and choose who wins and who loses. That's why we created a program, to show the passion of the country. With full understanding that we had the knowledge to supply pharmaceuticals and biologics that could delay, improve quality of life, and I might also add, reduce the overall health care costs to our country. If every member of Congress would just stop and recognize the fact that without treatment, we can predict on an annual basis that an HIV/AIDS patient will visit the hospital twice, once for pneumonia, once for a retinal problem, that the length of time will come to about $25,000 minimum hospital cost. You could justify the expansion of ADAP just on the roughly $13,000 per incidence you'd save, or per individual you'd save. But I don't want to suggest that we boil the program down to just those things that save us money. I think there's a principle here. And that principle is ingrained in what the President said the reason was that we were doing health care reform. Though he and I may disagree with how we did it, the end goal of both of us was the same: to expand the umbrella of coverage in this country. I don't know how you can aspire to that and then look at a subsection of the population and say, except for the products that you need. So, quite honestly, if you look at the history of AIDS in this country, the reason that we make the investment we do today is because enough people screamed. They screamed loud enough. They screamed in concert with others, and Washington was scared. What's the alarming thing is the health challenge hadn't changed, but Washington seems to ignore the need. And I would only encourage you, your willingness to be here, your willingness to be involved in the issue is absolutely crucial to our ability to provide enough funding to make sure that as Americans we can look at everybody affected by HIV/AIDS and feel confident that we're providing what's available to hold that disease in check. check for some period of time and to maintain some hope that there's a cure there. If we're not willing to do that, then I can assure you what the outcome is. The pot of money will dwindle as time goes on. More and more individuals will go without treatment. And in a state like mine that's already experiencing a large group who can't find the treatments they need, recognize the fact that this is not the typical HIV population of the past. This is African American females in rural parts of our state that have the biggest increase. We not only have the challenge of how to fund it, we have the challenge of how to deliver the drug. But I can assure you that states will never take on the challenge of trying to figure out how to get those products to the patient if in fact their belief is the funding will never be there. So it's absolutely crucial that we make sure we've got enough money to fund the need, and that funding always ought to follow the disease. I hope you'll do everything you can while you're in Washington, and if Washington is home, that you'll continue to rally groups together and to make sure that this is not something that just gets dropped. And I will assure you, the only thing I can promise you is that Tom Coburn and I will push this until this Congress ends either having, one, the money that's sufficient, or making sure that America knows that Congress turned their back on a very vulnerable population at a time of the greatest personal need that they had. Once again, thank you very much.